I am pleased to introduce Dr. Aloiya Kremer from St. Elizabeth Physicians. Dr. Kremer is a sports medicine physician and the new medical director for sports medicine at St. Elizabeth Physicians. She treats musculoskeletal conditions, concussions, and osteoporosis. She has completed her residency training in family medicine at The Ohio State University and her fellowship training in sports medicine at the University of Alabama. She is board certified in family medicine with a certificate of added qualification in sports medicine. She practiced in Dayton, Ohio with an orthopedic group for 4 years prior to joining St. Elizabeth this past May. Additionally, Dr. Kremer serves as the team physician for Ryle High School. Welcome, Dr. Kremer.
Thank you. Thank you so much, and thank you everybody for joining in this morning on the topic. Today I'm going to review thoracic outlet syndrome, and I'm going to start off with a case. So the case is of a 20-year-old male who's presenting with right upper extremity symptoms. He's a right hand dominant pitcher for a collegiate baseball team. And his symptoms started about 3 months ago with insidious onset. So there was no real preceding trauma or acute trigger for his symptom onset. He describes an intermittent tingling sensation in his forearm and hand, and he feels like that's in his entire hand, all fingers. He also describes an aching or fatigued sensation in his arm, some shoulder pain that's a diffuse shoulder pain, poorly localized, and occasional neck pain on the right side. His symptoms have been getting worse with the in-season demands of pitching, so worse with overuse, more repetition. And he's tried some ibuprofen and he's tried icing down his shoulder after pitching for treatment, but hasn't had relief with that. Symptoms do improve when he has a couple days of rest. So the differential in this case is broad, and given the topic of the presentation, thoracic outlet syndrome is of course on the differential for this case. And really the goal for my presentation today is to remind you to keep thoracic outlet syndrome on the differential kind of in the back of your mind, because it is much less common than a lot of the other pathologies of the neck and shoulder that you'll typically see. But it's one that can be missed because there's so much overlap with these other conditions. So if out of this presentation you get just keeping thoracic outlet syndrome in the back of your mind on a differential, I think that would be a good goal. But also I hope to give you some tools and pearls to kind of help tease thoracic outlet syndrome out from these other pathologies when you see a patient with it. So rotator cuff tendinopathy, subacromial impingement, and labral tear are some of the more common diagnoses that you'll see for especially overhead athletes presenting with shoulder upper extremity symptoms. On the differential is also peripheral compression neuropathy, so a carpal tunnel or a cubital tunnel syndrome, and then of course cervical spine pathology or a nerve root compression. On physical exam for this case, for this patient, he didn't have any tenderness around his neck or shoulder. His neck motion was normal, but he did have reproduction of his right neck and arm pain when he did right lateral rotation. So he's rotating his neck towards the affected extremity. His shoulder motion was normal, but end range abduction reproduced his tingling paresthesia symptoms in his forearm and hand. The strength in his shoulder was normal. And then on special testing, he had some paresthesia, some tingling with the NEAR test, which is an impingement test typically to try to reproduce pain symptoms in the shoulder. But with that end range kind of forward flexion of the shoulder, he did have his tingling paresthesias. He didn't have any pain with that test. And then on special testing for the labrum, O'Brien's test, bicipital load, labral grind, Speeds, and Jorgensen's test, those were all negative. He had a negative Sperling's test, negative Tinel's, so direct percussion over the nerve at the carpal and cubital tunnels was negative, did not reproduce his symptoms. And then at 90 degrees of shoulder abduction and 90 degrees of elbow flexion with external rotation of the shoulder, opening and closing his hands, which is the Ruse test position that we'll review, he did have reproduction of his symptoms with the tingling in his hand and forearm, and then pain in his arm as well with that. Diagnostic studies for this patient were overall normal. So he had normal x-rays of the C-spine and shoulder, and then his electromyography and nerve conduction studies were also normal. The outcome based on the history really of this patient's presenting symptoms and then a little bit based on his exam findings, he was referred for neurogenic thoracic outlet syndrome specific physical therapy. And his symptoms did slowly improve over the course of about 4 months. He was able to return to his prior level of pitching. So this case, for the sake of the presentation, I did keep it relatively simple and straightforward, but it's important to remember that a lot of times with this condition and how much overlap it has with other conditions, the course of the patient presenting and diagnosis and treatment isn't so linear, and a lot of times you might go down another path of treatment and then kind of switch directions or get more advanced imaging like an MRI, thinking along the lines of shoulder, and then you find that that's completely normal and doesn't explain their clinical presentation, so you backtrack, and that tends to be the more common way to get to this diagnosis of thoracic outlet syndrome. I know when I was in fellowship, my fellowship director used to say that this is one of those conditions that he thinks it sees more of him than he sees of it, meaning these patients may be coming in and we're maybe diagnosing it as something different, not calling it thoracic outlet syndrome, and the patient got better anyways. So that's something to keep in mind, is that it is relatively uncommon, but there's a whole lot of overlap with other conditions. And fortunately, the conservative management that we do for some of those other conditions in more mild cases of TOS are going to improve and help your patient. But again, hopefully throughout this talk, I can give you some pearls to help you tease out this diagnosis specifically. When you see thoracic outlet syndrome in general media, in popular media, it's typically in regards to a Major League Baseball player who has this condition. Because baseball is such a big revenue sport, there's a lot of financial implications to players missing time. So whenever thoracic outlet syndrome is in the headlines, it's typically regarding a baseball athlete. So definition and anatomy. The anatomy of the thoracic outlet syndrome is the interval between the supraclavicular fossa and the axilla, where you have the neurovascular bundle containing the subclavian vein and artery, as well as the brachial plexus running between the clavicle and the first rib. And symptoms of TOS are caused by compression of that bundle, and we'll talk about the different areas where that compression can occur. Based on those three structures, the nerve or the plexus, the artery, and vein, there's three different types of thoracic outlet syndrome. Neurogenic, which is compression of the brachial plexus, is by far the most common, with over 90% of cases of TOS being neurogenic in nature. And that category can be divided into an upper plexus thoracic outlet syndrome, a lower plexus, or a combined plexus, but the vast majority of these are lower and combined. I know that the 7 o'clock morning hour is far too early to talk about the brachial plexus, but just to keep it really simple, the lower plexus, which is one of the more common types, is going to cause numbness, tingling, or pain symptoms in the medial forearm and the ulnar hand. And combined plexus can really feel for patients like their whole hand or their whole forearm or arm have symptoms. And then venous and arterial, thankfully, they're much less common and much more clinically apparent, so you're likely not to miss these, and I'll show you some images and pictures later on cases of these that you can see the clinical findings. Arterial is by far the least common of the different causes of TOS. So pathophysiology, again, with the thoracic outlet syndrome basically being a kind of a tight, small area in the neck, and there's structures running through it. Those structures can sometimes get pinched, and that's really just the summary of this condition. So the areas where the neurovascular bundle can get compressed are between the anterior and middle scalene muscles, between the first rib and the clavicle, or behind the pec minor. Risk factors for this condition. Of course, anything that's going to occupy space in that already small space puts you at risk for getting some compression of the structures running through there. So more commonly, there's some soft tissue causes of compression, including scalene muscle hypertrophy and different aberrant insertions of that scalene muscle, as well as an accessory scalene minimus muscle. Sometimes you'll see anomalous ligaments or bands, like the costoclavicular ligament being in a position that's causing some compression, or soft tissue tumors. And then of the bony causes, a cervical rib or prominent C7 transverse process is relatively common among the bony causes of this. And then sometimes you can have a callus from a first rib fracture. That's a fracture that I've only ever seen in rowers, and it's typically in rowers like a stress fracture. But if you get a big, robust callus formation as that fracture heals, that bone can occupy space in the thoracic outlet. And then an AC or SC joint injury or dislocation can occupy space there, as well as a bony tumor. Focusing on the overuse cause of thoracic outlet syndrome, there are certain activities and sports that can cause scalene muscle hypertrophy in the neck. Overhead athletes are at risk for this. The overhead throwers, like our baseball athlete in the case, swimmers, archers, power lifters, and bodybuilders sometimes actually aim to hypertrophy their neck and scalene muscles for the aesthetic of that. And then wrestlers, occupational overuse can include anything where someone's doing repetitive overhead work, like a painter, or someone that works on a factory line where they're doing the same movement over and over and leads to hypertrophy there. So I've never Googled how to get a thicker neck, but I did for this presentation just to show some screenshots of there are articles out there and specific exercises that bodybuilders can do to try to achieve this aesthetic. And that does certainly put them at risk to get hypertrophy of the scalene and take up space in that outlet. And because I've now Googled that for this presentation, I'm getting targeted ads for this device, which is a neck strengthening device that actually sometimes football players will use this, because there's some evidence that neck strengthening can potentially reduce the risk of concussions just by kind of helping athletes to brace their neck for impact, is the theory behind that. But bodybuilders can also use this type of thing. So if you have a high clinical index of suspicion for thoracic outlet syndrome and your athlete seems like there's somebody who's strength training bodybuilding, might be a question to ask if they're using a device like this, because it certainly artificially loads those neck muscles much more than would happen naturally, and can really hypertrophy those muscles beyond what's natural. Okay, here's an x-ray on the screen of a congenital cervical rib. And a cervical rib is just an overdevelopment of the transverse process of a cervical vertebrae. Most commonly, it's the C7. So on this x-ray on the left, it shows a more prominent cervical rib, and on the right is a smaller one. And you'll see these in about 0.5 to 1% of the population. So typically, it's an incidental, clinically insignificant, asymptomatic finding. But if you have a patient that has a presentation that's leading you down the path of maybe this is TOS, this is something imaging that could potentially help to build your case for that. This is an x-ray of a pancreas tumor at the apex of the lung, and that's an example of a tumor taking up space in the thoracic outlet. So reviewing some clinical presentation on how these patients may present to you, focusing first on neurogenic thoracic outlet syndrome as the most common etiology. These are typically more commonly female patients, usually in their 20s, 30s, and 40s. And they present often with pain, and that can be in the neck, it can be the shoulder, arm, forearm, hand, or fingers. Sometimes tingling or numbness, arm or hand weakness, or they describe that they feel like they're clumsy, they're dropping things, losing dexterity. And a headache could be a presenting complaint because of cervicogenic nature of a headache. So things to focus on here in trying to differentiate it from other conditions of the shoulder and neck are these patients often present with a poorly localized pain. It's kind of diffuse. So typically, if you think rotator cuff, they're going to present with pain to the lateral shoulder. With labrum pathology, it's typically anterior or posterior shoulder, sometimes the axilla. And then with AC joint pathology, of course, on top of the shoulder. But these patients kind of have trouble localizing where their pain is, and it may involve the whole arm. But if it does stay kind of up near the shoulder, they can't really pinpoint where that's coming from. They also have a non-radicular nature of their paresthesia type symptoms, which this is a tricky one because I find a lot of patients struggle localizing paresthesias in general. For example, with a cubital tunnel or carpal tunnel, they often describe that their whole hand is numb and tingly because most patients, if they don't have a medical background, they're not thinking the way we're thinking of nerve distribution. They don't realize that there's one nerve for this part of the hand and one for the other. So they just know their hand is tingling and they can't really tell you where that's coming from. But certainly with thoracic outlet syndrome, especially if it's a combined plexus issue, they'll feel like their entire forearm or hand is tingling. Symptoms are typically influenced by position, and pain can be described as an ache, heaviness, or fatigue. So that was one of the key words in the case at the beginning, was that heaviness or fatigued feeling of the arm. Here's some pictures of venous thoracic outlet syndrome, and this is where the cases become more clinically apparent and again more rare. But with the subclavian vein not draining efficiently, patients get venous pooling in their extremity. So that can look like swelling. It can look like more vasculature in their chest or arm or shoulder. And then it can also sometimes have a blue or purple appearance. And because of that venous stasis in the extremity, they can develop a DVT. With arterial thoracic outlet syndrome, this is tremendously rare, but these patients will present with pain both at rest and with activity because they're dealing with ischemia. So their tissues are not perfusing, and that's painful for them at rest, certainly much worse with any kind of activity. Their hand can appear cold or white in color. So on this larger picture on the slide, on the left side, that is the affected hand where it appears more white. They can have a decreased radial pulse and delayed capillary refill in their fingertips. And then sometimes they can have a thrombosis and shower emboli to their digits. So that's the smaller picture on this slide is an image of digital emboli, that dark maroon, purple, or black, dark brown discoloration with kind of a spotted appearance. On physical exam in general for thoracic outlet syndrome, it's important to include a complete neck and shoulder exam to rule out some of the more common conditions. And then for thoracic outlet syndrome specifically, palpating the supraclavicular area can reveal either tenderness, fullness, or mass in that area. It would be a rare finding to see a blood pressure difference between extremities, but that can be seen in vascular cases. And you'd have to have a high clinical index of suspicion because typically you're not going to check a blood pressure in both arms. But a difference of more than 20 millimeters of mercury between extremities is pathognomonic for this. It's important to compare their affected extremity to the contralateral extremity to see color, temperature, if there's any edema or atrophy, and vasculature. The image on the slide is a picture of the Gilliatt-Sumner hand, which can be seen in more progressed cases of neurogenic thoracic outlet syndrome, where you have atrophy of the abductor pollicis brevis and the hypothenar musculature, as well as the interossei. There's no great physical exam test for this condition, which adds to the complexity of diagnosing and recognizing it. I kind of think of it like the labrum and concussions, where both of those things, there's no one test that is really great for making a slam dunk diagnosis. But if you combine multiple special tests and you kind of build that with the patient's history, you get an increase in your specificity. So this top left picture is demonstrating the right test. And it's a test where the patient's arm is abducted and extended or externally rotated back, and they're turning their head towards the unaffected side. The clinician is palpating the radial pulse. And if the pulse dampens or obliterates, that's considered a positive test. There is a decent amount of the normal population that will have a positive right test. So comparing to the contralateral extremity may be of benefit, but know that this has a high rate of false positives. Same is true for the Adson test, and on this test, it's also palpation of the radial pulse, but the patient's arm is hyperextended back behind them, and they're turning their head towards the affected side. And with this one, the patient is instructed to take a deep breath in, and that's when the pulse is palpated to see if it's reduced or obliterated. And then the third test here is the bottom two pictures, which is showing the Ruse test. And this was the test that was positive in our patient case at the beginning, where the patient's in a 90-degree abduction and elbow flexion. They open and close their hands for 3 minutes, is what's kind of the definition of the test. And we're looking for a reproduction of their symptoms or asymmetry, where they say, oh, my right arm is getting so tired, but my left arm is still fine. I've never done this test for 3 minutes straight. I think that would feel like a lifetime in the office clinically, but when I have seen cases of this, their symptoms are reproduced in like 45 seconds or less oftentimes. Diagnostic studies, kind of same principle is true here, where there's not a great test per se in most cases, especially the more mild cases. But getting a chest x-ray, C-spine or shoulder x-ray can be beneficial, especially if you're looking for that cervical rib as a potential risk factor. EMG and nerve conduction study are often normal, which makes things difficult, but in more advanced cases, you may see some latency in the conduction of the C8 and T1 in that lower plexus, including like the median motor nerve and the antebrachial cutaneous nerve. Those can be abnormal. That's the typical pattern if the EMG is going to be abnormal, but it is most often normal. If you have a suspected vascular case, ultrasound is really the initial preferred imaging test because it's cheap, it's dynamic, it's very low risk to the patient, and it's a pretty sensitive, specific test for that. MR neurogram are the images that are shown on this slide, which is a type of MRI that really can localize the brachial plexus and its compression. So on both of these images, you can see some pinching of that plexus on the picture there. Venogram can be used for vascular venous cases, and then traditional angiography is typically not used because it can show that there's compression, but it doesn't show what structure is causing that compression extrinsic to the neurovascular bundle. But MR angiography can help with surgical planning if you have a patient going down the route of needing surgery. Moving into management. Most patients, again, are neurogenic causes, and most of those patients typically will do conservative management indicated first. And that involves some activity modification, so either reducing their workload or repetitions, taking a rest from their sport if needed, and physical therapy, typically recommended for about a 6-month trial before determining whether or not it's been successful for that patient. NSAIDs can help with symptom relief, and then SSRIs, SNRIs, and anticonvulsants like gabapentin and pregabalin or Lyrica and Neurontin can be used as adjuncts for symptom control. There's some evidence on injections. There was a randomized controlled trial that there was no significant benefit of doing Botox in the anterior scalene muscle, but there's possible diagnostic value there where if it does help their symptoms short term, that may kind of help support your diagnosis. And then doing a corticosteroid injection with anesthetic actually with or without the steroid, into that anterior scalene or the pec can give the patient some symptom relief, and it can also be a prognostic indicator if they're headed down needing surgery, not getting better with therapy. If they have success with that block or with that injection, it does show 14% higher rate of good surgical outcomes. In vascular thoracic outlet syndrome patients, the vast majority of these are surgical, but in very mild cases of ischemia, you may be able to do a trial of catheter-directed thrombolysis and systemic heparin before moving on to surgery. When it comes to surgery for this condition, indications for that are, again, most cases of the vascular TOS, and then for neurogenic, if they haven't had significant improvement after 6 months of therapy and medication, or if they've done 4 months of that and there's just no trajectory of improvement at all, like they're just totally stagnant, plateaued, that may be an indication to consider surgical decompression. And then, of course, before that, if they're having uncontrolled, progressively worsening pain or weakness. The procedure itself is typically done by a vascular or thoracic surgeon. I think there's some orthopedic surgeons that will do this as well. And it's a decompression where the first rib is resected just to give that outlet more space. And then there's also a scalenectomy or scalenotomy done with that. The costoclavicular ligament is resected, and then neurolysis, where the perineural scar tissue can be freed up with or without resection of cervical rib if it's present and large. There's 3 approaches for this: transaxillary, supraclavicular, or infraclavicular, and it's really surgeon dependent and preference there. And there is the option for robotic or scope assisted approaches to minimize manipulation of the brachial plexus. The good news with surgery, if the patient progresses to needing that, is it's tremendously successful with about 90%, 95% excellent outcomes. So in summary, thoracic outlet syndrome is rare. Of the cases, neurogenic is by far the most common type. And the diagnosis relies really on good history taking and physical exam. The history is really your best tool with this. Combining special tests on exam can lead to better specificity. Combining the RUSE test with the Adson test leads to an 82% specificity. And imaging and nerve studies can potentially be an adjunct to your diagnosis. Initial treatment is typically non-surgical, recommended to do a 4 to 6 trial of conservative management. And if a patient does need surgical decompression, it has excellent outcomes. Thank you so much, and we will progress to the question and answer session. Thank you for joining in this morning.
Okay, we have a question. So when performing clinical special tests for thoracic outlet syndrome, we are palpating it at the distal pulses to determine if there's a loss of a pulse. Would a loss of a pulse only be for venous thoracic outlet syndrome, or could we see it with neurogenic thoracic outlet syndrome?
That's a great question. So the structures in the neurovascular bundle are all kind of tight together. So it's interesting that there's so much differentiation and that we don't see more overlap between those vascular and neurogenic causes. But that all 3 of those special tests are indicated for neurogenic thoracic outlet syndrome as well as the vascular causes.
Is there a preferred sleeping position for patients with thoracic outlet syndrome?
This is kind of trial. Do you want me to repeat that question?
No, you're good.
Okay. This is kind of trial and error with the sleeping position. Same with patients that have like shoulder impingement. A lot of times if they're overhead, kind of sleeping up on their arm, they're just creating more impingement in that space. And the subacromial space is kind of near the thoracic outlet. So a lot of those positions are similar that will reproduce symptoms. So often the patient will want to sleep with their arm lower and maybe a pillow between their arm and their body, but it's really trial and error to see what works best for them.
Are there any exercises that should be avoided if a patient has TOS?
The exercises that should be avoided is anything that's aggravating their symptoms, which is often going to be overhead. So people who do strength training or go to the gym find that their symptoms might be worse with like overhead press, bench pressing, shoulder presses, those kind of things that really pinch that area. But anything that reproduces their symptoms can be avoided to try to reduce their symptoms.
Are there any genetic components to TOS?
I'm not sure there's great evidence, at least that I've come across on a genetic etiology, but I think probably just because of the anatomic variants that can be a risk factor, like those accessory scaling muscles or accessory ligaments, potentially there's a genetic component to that.
St. Elizabeth has an upper extremity injury prevention program. Would a program like this help to prevent TOS also?
I think it would be great, especially athletes or people that are at risk for the overuse repetitive risk factor for this. It's really tough to change an athlete's form. I'm thinking baseball pitchers, especially once they're at like the high school, college level. But if they're having something with their form that's leading to some sort of compensation up in the neck shoulder area and they're getting scaling hypertrophy, that may be something to consider, is trying to get an assessment of their form and using our upper extremity injury prevention program to work on stretching the scaling muscle, stretching the pecs to release pressure off of that outlet.
Can the symptoms of neurogenic TOS centralize as it often does with cervical radiculopathy?
Centralize. So I'll move back up towards the neck. This is one that's tough because the symptoms are so diffuse and patients can present with neck pain to begin with. I'm not so sure that as the condition progresses, symptoms become more localized and centralized up towards that outlet or where the compression is. I've not seen it clinically, but potentially.
This says, what is the typical management protocol for Horner syndrome post decompression/surgery?
That is a great question. I'm not exactly sure the answer to how that would be managed. It's a tremendously rare potential risk of the surgery, thankfully, but I would refer to a specialist in that case.
What are the risk factors for thoracic outlet syndrome?
So the risk factors are the occupational or athletic overuse, and then any of those bony or soft tissue space occupying lesions in the outlet.
Would an athlete's weight have anything to do with them getting TOS?
I think maybe less of weight on its own and more of the hypertrophy. So those bodybuilders, they're going to have a higher weight, but they're isolating those neck muscles more. So I think that's the bigger risk factor there.
I think this is our last question. Is thoracic outlet syndrome treatment needed urgently?
It depends on the cause. So vascular thoracic outlet syndrome is definitely more of an urgent, especially the arterial is certainly an urgent case. The neurogenic, if their pain is under good control and they're not having consistent, progressively worsening numbness, weakness in their extremity, that's something that we can certainly take our time with more.
Okay. One more question. What is thoracic outlet syndrome typically misdiagnosed with?
Typically, it's misdiagnosed with kind of overuse shoulder pathology like a rotator cuff syndrome, subacromial impingement, possibly can be misdiagnosed as a labral tear, and then certainly like a cervical nerve root compression or peripheral neuropathy.
They keep coming in. What are complications from surgery?
So Horner syndrome was mentioned. Complications from surgery are rare, but manipulation of the brachial plexus during surgery can sometimes lead to patients having some persistent neuropathic type symptoms. Injury to the vasculature there, to the subclavian artery or vein, would be tremendously uncommon.
Okay. I think that will wrap up the question and answer period.